Hello, this is Hussein Zainuddin and I will be discussing our chapter Laser Interstitial Thermal Therapy in Epilepsy. The objectives of this chapter is to discuss the evolution of LIT in neurosurgery, to describe the applications of LIT in epilepsy in particular, and to illustrate some operative cases of LIT. The development of LIT started as early as 1916 with Einstein's theory of spontaneous emission. This was followed by Townes and Gordon's invention of the first maser in 1953. In 1960, the first ruby laser was revealed, and very soon afterwards, in 1961, the laser was already being applied to medical use. In 1965, the laser was used to treat carcinomas in humans, and by 1966, the use of laser in a GBM case was described. By 1983, the interstitial laser thermal therapy was described, and then by 1988, the development of clinical MRI thermal monitoring started, and this allowed the combination of both a laser thermal therapy with clinical MRI monitoring. In 2012, we witnessed the first experience for epilepsy use of LIT by the use of a commercial LIT software. The use of LIT for mesial temporal lobe epilepsy is probably the most common application of this technology. Surgical resection has long been the gold standard for treatment of medically refractory mesial temporal lobe epilepsy. Anterior temporal lobectomy can result in seizure-free rates as high as 60 to 80%. However, this technique has been linked to cognitive impairment and focal neurological deficits. With the advance of LIT, it is possible to achieve seizure freedom while minimizing adverse effects. Studies have shown better neurocognitive profiles in patients, including naming and recognition of noun, visual field deficits after LIT found an octanopsia to be the most common focal visual field deficit, which occurred in up to 37.5%. However, it is still much less than that seen after ATL. Serious neurological deficits such as hemiparesis, are rare with LIT and notably lower than those with open procedures. This table right here summarizes most of the largest studies in patients with medial temporal lobe epilepsy undergoing laser interstitial thermal therapy. Taken together, the results are encouraging, with Engel Class 1 outcomes at 12 months being in the range of around 40 to 60%. Failure of seizure freedom may at times be related to residual hippocampal component that might be targeted with another ablation session if needed. Studies have found that the majority of recurrences occurred in the first year after LIT. Repeat surgery as well as repeat LIT may be required and has proved to be effective in achieving improved seizure control in up to 70% of cases, although the sample size in the literature is small so far. While this success rate is lower than that seen with the gold standard ATL, LIT holds major therapeutic benefit relative to medical therapy alone. Furthermore, undergoing LIT does not preclude further traditional open surgeries should this be needed. The figure here illustrates a sample case of LIT for mesial temporal lobe epilepsy. For optimal ablation, the probe is inserted via an occipital approach along the long axis of the hippocampus and into the amygdala. The trajectory should be planned to avoid vasculature, the choroid plexus, and the ventricle if possible. The ablation starts at the most anterior portion, targeting the amygdala in this location, and using real-time feedback, the catheter is withdrawn in successive stages for further ablation along the long axis of the hippocampus. Following this, the laser, its applicator system, and its anchoring bolt are removed, and the stab incision is closed. Patients tolerate the procedure well and are typically discharged home the next day. Sparing of the mesial temporal head was associated with failure of treatment in a number of studies. Furthermore, extending the ablation posteriorly is counterproductive. In a recent meta-analysis, it was found that ablations, including more anterior, medial, and inferior temporal lobe structures, which involved greater amygdala volume, were more likely to be associated with higher seizure freedom. In conclusion, while LIT provides a lower rate of seizure freedom compared to open resection, It does so in exchange to reduced complication rates, reduced morbidity, and shorter hospital stay. The options of further ablation in cases of residual hippocampal remnants or even open surgical resection are both feasible after a failed LIT. Ideal medial temporal lobe epilepsy candidates remain to be defined, along with the optimal trajectory, ablation zones, and ablation volumes. While strong evidence in regards to the use of LIT in mesial temporal lobe epilepsy currently exists, a prospective study by the name of stereotactic laser ablation for temporal lobe epilepsy, SLATE, is underway. It aims to quantify outcomes in carefully selected cases. This multi-center study, designed to evaluate the safety and efficacy of LIT for ablation of epileptogenic foci in patients with intractable mesial temporal lobe epilepsy, aims to include around 150 adult patients with drug-resistant mesial temporal lobe epilepsy, treated at selected epilepsy center with follow-up up to 12 months post-ablation. Primary endpoints of the study are incidence of qualifying adverse event and seizure freedom at 12 months. Extratemporal epileptogenic foci have also been targeted by LIT. This slide focuses on LIT application for focal cortical dysplasias. FCDs are a common cause of refractory epilepsy that typically result in seizure onset in childhood. While complete surgical resection enable high cure rates, the deep and eloquent location of some FCDs can make this surgically challenging in some cases. The seizure freedom rates for FCD after LIT range from 50 to 100%. This is a reflection of the evolving nature of this technique. Regardless, this technique does offer a relatively low morbid option in patients in whom the risk of operation is high and in whom the FCD is deep-seated or adjacent to eloquent location. Another form of extratemporal epilepsy targeted by LIT is insular epilepsy. The rapid adoption of SEEG across many epilepsy programs in North America has led to the detection of a greater number of cases of insular epilepsy than before. Surgical excision has proved to be successful, with up to 80% seizure freedom in the larger studies. However, it carries significant risk given the vascularity of the insula and its proximity to critical cortex and white matter tracts. A retrospective review of pediatric patients comparing LIT-treated insular epilepsy versus open surgical resection suggests comparable rates of seizure freedom between the two interventions, even though the LIT outcome was slightly lower seizure freedom than the open resection. The complication rates was similar on both groups. The reason for the lower success rate with LIT may be related to the extent of ablation achievable compared to open surgery. The proportion of insula ablated, as well as the ablated volume, do appear to correlate positively with seizure outcome. Overall, LIT provides a new treatment option for insular epilepsy that, while probably less effective than open surgery, has an acceptable success rate and perhaps a more favorable adverse profile. LIT has also been applied to epilepsy resulting from tuberous sclerosis. Epilepsy is one of the most common clinical presentations of tuberous sclerosis and affects up to 90% of individuals. Medical management leads to control in around 1/3 of the cases. The rest are considered for surgical intervention if the tubers are surgically accessible. If associated with multiple tubers, single or stage resection can be arranged. In a large series of 74 patients, surgical intervention yielded angle class 1 in 65% of cases at 1-year follow-up. However, the authors also noted complication rates ranging from 2 to 5%, including neurological deficits, wound complications, and CNS infections. While the experience of LIT with tuberous sclerosis is still limited, preliminary data suggest a benefit on seizure control, but not as high as that of surgical resection. Reasons behind the apparent lower rate of success with LIT compared with open surgery is likely related to the extent of ablation, as studies have shown that greater extent of resection, more than just the tuber, is associated with higher likelihood of seizure freedom. Hypothalamic hamartomas have also been a well-described target for LIT. Hypothalamic hamartomas are rare developmental malformations of the ventral hypothalamus that are associated with precocious puberty and gelastic seizures, and are typically associated with refractory epilepsy, usually resulting in complex partial seizures or gelastic seizures. Given their deep-seated and critical location, they are an ideal target for LIT, and they represent the most frequent indication for LIT in the pediatric epilepsy. This figure demonstrates the lesion and the paper probe on the left side, and the right figure demonstrates the immediate post-ablation scan. This table summarizes a number of reports about LIT for hypothalamic hamartomas. Taken together, they suggest marked efficacy and low morbidity of this approach. In one of the largest studies, 97% were seizure-free at 1-year follow-up, a number significantly higher than that reported with open surgical resections. Furthermore, LIT has significantly better safety profile than open or endoscopic resection for hypothalamic hamartomas. For instance, memory loss after LIT is around 1.5%, compared to higher rates up to 15% with surgical resection. Furthermore, the hospital length of stay is also significantly less, with the majority of patients being discharged the next day. LIT has also been applied for periventricular nodular heterotopia-related epilepsy. PVNH results from abnormal neuronal migration during development, leading to the presence of ectopic nodules of apparently normal brain cells in subappendimal locations. Seizures arising from these nodules are typically drug-resistant and necessitate surgical intervention. However, the deep location of the lesions makes it surgically challenging to access and resect, particularly in multifocal cases. LIT thus represents a reasonable alternative. Though limited in number, available evidence has been encouraging. Even though with a low number of reports, the results show that around 70% of patients are seizure-free at 1 year of follow-up. The images here demonstrate an illustrative case for PVNH with LIT. The left upper figure demonstrates the lesions, which were proven to be the ictal zone by SEEG. The right figure demonstrates the application of 2 laser probes to fully ablate both pathologies. The left lower figure is a follow-up scan after the ablation. This particular patient remains seizure-free at 12 months. In conclusion, LIT is a rapidly evolving technology that is being applied for an increasing number of types of focal epilepsy. It has an improved risk profile compared to traditional surgery. While that is exchanged for a lower likelihood of seizure freedom in pathologies such as medial temporal lobe epilepsy, LIT does not preclude further intervention if required. LIT, however, does have a better profile and a better outcome in certain pathologies such as hypothalamic hamartomas. It is also being applied to other pathologies such as cerebral cavernous malformation resulting in epilepsy, or even for corpus callosotomy, even though the reports are still very early. Future studies that provide insight regarding patient selection, long-term outcome, trajectory optimization, optimal ablation volumes, and comparison with other stereotactical technologies are desirable.